It's fair to say that the past 9 or 10 months have seen unprecedented disruptions in the fields of global health and global health security. There was the January 20th announcement of the United States' intent to withdraw from the World Health Organization. That action halted transfers of funding or dues to the organization, recalled US government personnel working there, and terminated all engagement in negotiations related to the pandemic treaty and the international health regulations. The same day also saw the release of the executive order on reevaluating and realigning US foreign aid. Stop work orders, award suspensions, waivers, a foreign assistance review, and the announced dismantling of USAID followed in short order. Alongside all of that activity, there was a lot going on at the Department of Health and Human Services, including an abrupt termination of pandemic-era fund transfers for states and localities to strengthen outbreak preparedness, the Secretary's delayed endorsement of the measles rubella vaccine, and promotion of unproved alternative treatments in the midst of the worst measles outbreak since elimination in 2000. The April 1st reduction in force that dismissed hundreds of public health experts from CDC and other agencies. The dismissal in June of a significant chunk of the members of the CDC's Advisory Committee on Immunization Practices. And an attack in early August on the CDC by a gunman frustrated over COVID-19 vaccines, followed later that month, or in August, of the recently confirmed director, Susan Menares, and resignation of 4 top leaders. And then there's PEPFAR, overseen by the State Department, but really an interagency program involving USAID, CDC, Peace Corps, the Department of Defense, and others. The latest budget requests reflect major cuts to PEPFAR, as well as the Global Fund, to which the US has historically been the major donor, and which, like Gavi, the Vaccine Alliance is having a replenishment period. Amid all of this, in late September, the State Department released the America First Global Health Strategy, a sometimes contradictory document which highlights PEPFAR achievements and stresses efficiency and accountability as part of a new vision for the US, while at the same time scaling back program funding, staff, and implementation capabilities. And just this past weekend, there was a fresh round of rifts affecting biodefense, including outbreak monitoring and response at HHS, with some positions restored on Saturday amid considerable confusion. There are a lot of questions. Where's Congress in all of this? Is bipartisanship even possible in this period of frustration, polarization, and challenges? What's happening at the White House? And what are other agencies like the Department of Defense, which have historically played a strategic role in global health security, what are they doing in this period? With the United States seeming to pull back from the global health stage, is anyone else, countries, philanthropies, private companies, stepping in to fill the gaps? We know that trust in public health and science is at a low, particularly since the pandemic, but is all of this really what the American people want? Is this going to be creative destruction? That is, a process that leads to new innovation and value, or is it just destruction? In short, what is the future of global health? So, speaking of COVID, it's hard to believe in some ways that it's been more than 5 years, but it has. It seems still with us in so many ways. And it's really kind of paradoxical that in just 5 years since the start of the worst pandemic to hit the country or the globe in recent memory, we've seen the White House essentially dismantle or ignore the Office of Pandemic Preparedness and Response, just only relatively recently set up. The NSC, National Security Council, which played such a significant role during COVID, nowhere to be seen. The recent cuts at Health and Human Services over the weekend led to the dismissal of experts from ASPR, the Administration for Strategic Preparedness and Response. And so, a huge loss of people who have deep expertise in looking not just at pandemics, but also the weaponization of pathogens or bioterrorism, which, going back the 22, 23 years, this quarter century of work on global health and global health security that you were talking about, a lot of that really got started after the anthrax attacks and, the discussions in the early 2000s. So how do you see the recent developments over the last 9 to 10 months affecting the world of pandemic preparedness and response and biodefense? What's happening?
Well, as you point out, we've disarmed ourselves in many ways. We've gotten rid of the Office of Pandemic Preparedness and Response at the White House. We've eliminated the directorate at the National Security Council. The HHS, Office of Global Affairs, really doesn't do much now. The Bureau for Global Health Security and Diplomacy at the State Department does not have a nominated and empowered assistant secretary. And you can go on and on. There's been some similar problems at the DoD, although less severe. There's no desire, or there's no evidence of a desire to engage China in any meaningful way at a senior level about shared threats. There's still this sort of quagmire or stalemate that's rooted in the unresolved COVID origin debate that goes back. This bitter and rancorous thing seems to stall out having questions, having any kind of meaningful dialogue. Cutting off WHO has consequences. What are we replacing it with? Some of the senior experts in this field on health security and preparedness have looked at that environment and said, this is completely unprecedented that you would have the United States systematically disarm itself. And what does that mean? That means that we are going to be running blind or half blind into the future as these threats come forward. Our surveillance, our response capabilities, our interagency process are missing in much of this. And bad actors are going to see this for what it is, which is an opening to do malevolent and destructive things that we need to be on top of, and we're not going to be there, as well as the accidental or naturally causing threats that emerge. Now, there has been some hesitation in this front. At the new Global Health Security Strategy that the Department of State, that Secretary Rubio issued a short while ago, had a very strong statement in there about continuing to support the program of preparedness in response to emerging threats. You have the legacy of the Trump National Security, Global Health Security Strategy of 2018. So you can go back to that. We've been issuing reports. We did one in June. We're doing it. We have a biodefense group now looking at the key elements of that strategy, and the June paper that the Alliance put out was a way forward around restoring and revitalizing capabilities in health security. It was well received. I mean, it was shopped around to many different folks on the Hill and the administration alike. It did not meet with resistance. It met with a lot of interest. The announcements, the RIFs that were announced, the reductions in force, 1,300 reductions in force at HHS announced last Friday, with bulk of those coming out of CDC. ASPR, as you say, at HHS was very deeply damaged. But then they reversed course.
Some came back. Yeah.
They reversed course and made clear that the global health centers were going to survive it. For us as a country to sail forward unilaterally to put together any kind of capabilities, if we're withdrawing from WHO and the like, we need country offices. The CDC country offices are going to be even more important to us. And so those are being preserved. There have been exemptions in the announced withdrawal from WHO. There were several waivers that allowed for continued technical contact on some of these key areas, like the pandemic flu, the monitoring of smallpox, and other things. That was evidence of an awareness of the need to protect Americans by preserving those channels. Now, we don't know what happens on January 22nd of next year when the final break happens, WHO, and whether there will be those kind of conditions still there. Let's be hopeful that they will be. So I think we are acutely vulnerable. I think it's extraordinary what's happened. It's not irreversible. I think the depth of damage, is not as severe as global health, as the global health programs. Partly because I see a very determined effort coming out of the White House, out of Russ Vought and OMB, to really drive those global health programs into a much different, much smaller position. I don't see that same drive directed, the same vitriol against the health security world. It's been damaged, it's been set back, there's a disregard, but then we see this evidence of a sort of, well, wait a second, we need to. So there are some nuanced things happening there. But let's turn now to global health and global health security, a global health strategy. We just have this new strategy. You've been watching carefully what's happening with PEPFAR. PEPFAR was in the barrel in big time. It was severely disrupted. There were waivers applied early in the Trump administration. They were not implemented very well. So the delivery of services, the interruptions in data systems, the loss of personnel, the loss of implementers was not corrected. And so it's suffered pretty grievously, but it survived up to a point. So how do you see the status now? Let's talk about that flagship program in global health.
So there's been a lot of whiplash, it seems like. I mean, from day one announcement, as you said, of cuts, there have been lawsuits, there have been program terminations, there have been restoration, the waivers, as you mentioned, and confusion about the definition of the waivers and what activities would be acceptable and what wouldn't. I think amid all of that, though, has been an abiding appreciation for the fact that PEPFAR has been the flagship global health program, at least since 2004, credited with saving more than 20 million lives and, really, I think, serving not only in the delivery of HIV services, but in many ways anchoring a transformation in health systems in many of the implementing countries towards strengthened laboratories, strengthened health workforce, and strengthened surveillance systems and the like. And we certainly saw that during COVID as well. We saw the PEPFAR programs really being sort of serving as foundations for increased testing for COVID, for the delivery of vaccines once they were available, for training of health workers and the like. And so I think it's no surprise to see PEPFAR kind of serving as an anchor within the new global health strategy. Yes, PEPFAR has been significantly reduced. Already, but even before the strategy, there was the struggle over reauthorization that played out, between 2024 and sort of, then you had the 1-year extension to 2025. But, and then certainly, you and Gerard Radivosian, senior associate with our program, and I and others, have written about some of the ways to, begin to think about a transition of PEPFAR over time, kind of to 2030 and beyond. So I think, in seeing the focus on, PEPFAR as an anchor for some of the other kinds of infectious disease programs, I think that's not surprising, but it may not be sufficient for carrying out the kinds of innovation and efficiencies that the program is, or that the new strategy is really envisioning. There's a lack of detail about how malaria and tuberculosis and other infectious diseases will be somehow integrated to the PEPFAR platform, whether that's funding or program delivery, particularly what's left. And then there are so many other aspects of global health that are just not treated in that strategy. There's really no discussion about what were like huge bilateral programs around supporting immunizations and, really complementing a lot of the work that the U.S. was supporting through Gavi. There was the whole work on family planning, which is just not discussed at all. That's been eliminated. And then, we know that increasingly, alongside infectious diseases in many parts of the world, non-communicable diseases are an increasing source of mortality and disease. And not clear how the U.S. Will take that on. Is it going to? Maybe that's not an area of focus, but that could align with the Maha agenda. It might not. And then there's the issue that we've been working on a little bit with the Climate and Health Working Group, which is extreme heat, and the increasing role that climate change will exact on health, whether that's reducing the impact of existing investments and making it more difficult to access health systems that are already in place, or creating new health hazards as well. And so, while I think it's important to see that existing programs like PEPFAR, are really kind of the node of the new strategy, I think there are a lot of gaps and questions that remain.
I mean, the strategy is the new global health strategy that Secretary Rubio put out a short while ago. It's saying, okay, there's going to be compacts, and they're going to do them really fast. And
By the end of this year, right?
By the end of the year, and they're focusing in the first phase on the top 16 partners. That accounts for, 90% of the dollar flows. Mm-hmm. So those 16 countries, they're going out and they're saying to them, we want to do a multi-year agreement with you. What that means, 3 years, 5 years, I don't know. But they're saying, okay, now there has to be a much more serious upfront commitment.
And so co-financing,
co-financing,
right? Country-led,
much more of that, and we don't want the NGO implementers in the picture. Mm-hmm. What does that mean in terms of we want to be investing much more in commodities, medicines, and health workforce. We want to get out of the very expensive delivery mechanisms through the American NGO groups that dominated in that. So administrative costs are supposed to drop significantly. They're supposed to get into direct relationships with these 16 governments. There's actually 71 government partners, but those 16 are the core ones. And that's going to be the new model, and they're going to put a greater emphasis on U.S. private sector business. There'll be some transactional aspects to this, and it's going to be very short term. In other words, they want to see a phase down, a phase out of not all countries. They're admitting that many will continue to need U.S. support, but they're putting the onus back on African leadership and other leadership to come forward with much more significant commitments up front. And they're looking at a delivery model that is radically different than what existed beforehand. And I think beneath the surface is the idea that the Global Fund will continue as a partner, even if at radically lowered U.S. support. The Global Fund's heading towards its replenishment. Mm-hmm. U.S. is saying it's going to go at least a half of prior levels and perhaps lower than that. But keeping that going, keeping the CDC country offices going is going to be very important. But it's going to be a different world. And we don't know whether the intentions of the administration are serious about this, because we know that Russ Vought and OMB are impounding foreign aid. They did $8 billion earlier. They did $4 billion earlier. The courts are letting them move ahead on that. And these newly appropriated monies, Congress has been missing from the picture. We don't know where they come back. And how is this going to be administered, right? They've just slashed all of these capabilities. And managing this money, Congress is not going to roll over and say, just write checks. I just don't know. I mean, so it's going to be a very interesting time. And for PEPFAR, I would expect we're going to see several countries graduate in 2-year, 3-year time frame.
Well, and it's an interesting period, too. You have all this contraction on the one hand, and yet new innovative approaches to prevention on the other. So we did see that new partnership announced between Gilead, the Global Fund, and the Department of State, really focusing just on a fairly small group, just 2 million, largely, I think, pregnant women to receive the prevention. But it's a start, and it's at a moment that really is ripe for perhaps integrating into these.
And it matches up to the theme of technology and innovation and private industry and Gilead Sciences, and that's a good fit, and that's a promising thing.
Yeah. All right, so there's one silver lining, but this comes back to the question that we kind of tackled at the beginning, which is maybe not so much is there a future for global health, but what is the future for global health? Is there a bipartisan path forward, and what do you really kind of expect to see over the next 3 to 5 years?
You're talking in terms of U.S. leadership.
In terms of U.S. leadership at this point.
Yeah.
Yeah.
Well, we're at the end of a 25-year era. There will be no restoration. We're not going back. We are in the process of a reset. That reset is going to be at much lower funding levels. It's going to be much more negotiated. The onus is going to be back on our partner country leadership to come forward and their dependence, their long-term dependence on the U.S. and other donors is ending. And so if we're going to move ahead, it's going to be in a context in which we see higher commitments, political and financial commitments coming from our partners. There's been the Accra reset back in early August. There was the follow-on summit on the margins of the UN General Assembly. There's been a lot of rhetoric and a lot of promising sort of developments. We'll see what happens there. If we see a different form of renewed leadership on the side of African statesmen and women and those in other partner countries outside of Africa, and this administration is signaling it wants to move in that direction, we could see a new form of engagement come forward. But it's going to be fewer countries, lower budgets, shorter timelines, very dependent on those prior commitments, on that kind of leadership coming forward. It's not going to be multilateral. There'll be some linkage to the fund. They'll be reliant on the CDC country offices. But I want to add here that dangerous outbreaks are not going to go away. Infectious diseases are going to still be with us. Malevolent, accidental, and natural causing serious dangerous threats are going to still be with us. Humanitarian crises are going to be with us. I mean, even though we haven't talked much about the humanitarian response, but those capabilities, those budgets have been reduced significantly at the same time, which is
They make it very hard to deliver just basic health services like immunizations or anything else.
So we just had the breakthrough in Gaza, and a commitment by the U.S. government to send a DoD contingent from the Central Command, 200 staff, into Israel to coordinate the logistics and delivery on the humanitarian side, and presumably on the disarmament or whatever happens in terms of a stabilization force coming in. We had a State Department announce it's sending a DART team out. Well, that's an interesting development, and it shows that in priority areas of foreign policy, there's still an impulse to reach for the U.S. leadership in this domain, and some of these mechanisms are still there on both the civilian and the military side, and there's an appeal to that. So I guess I don't think that we are going to see a disappearance of U.S. engagement on global health. It's going to be very different than what we've seen before. There will be no restoration. I think the PEPFAR program is going to bear a careful watch as to how that transition is managed, because it's a dangerous one if it's mismanaged. We haven't talked about the fact that South Africa, which is the epicenter of the global HIV/AIDS epidemic, and which is
totally cut off.
A huge partner with the United States, the biggest partner on HIV and many other things, is now in the doghouse. It's cast as an adversary for other geopolitical reasons.
Right. The research has been cut off.
And so there's this whole question mark. Well, what does that mean? If you don't have an active and fruitful partnership with the South Africans, it just disrupts many things. And look at India. In the case of India, we've imposed 50% tariffs on this country.
That's where most of the pharmaceuticals come from for PEPFAR and others.
Right, and that's where most of the generics on vaccines against dangerous outbreaks are coming from, other dangerous. So we've got some reordering to happen on the geopolitical side if we're going to have a meaningful impact. And we talked earlier about not having any dialogue with the Chinese just limits our engagement on these critical issues of health security, but also it opens the door to them. What we've done in this period is open the door for expanded Chinese influence. So far, we don't see all that much action to exploit those openings, other than the rhetorical, showing 200 Chinese showing up at the World Health Assembly, and we have no one there officially for the first time since 1948. That was a fairly stark thing, but we're gonna have to move forward here.
Well, I think there's plenty of grist for a next phase of this conversation for sure. There's a lot to keep our eyes on geopolitically with respect to this kind of generational shift in thinking about U.S. engagement in the world, and really, where the American public and Congress are in terms of responding to many of the changes. So thank you for sitting down with me today.
Thank you.